every one of us that has graced this occasion to come and listen to the mental and the and the psychiatric pharmacist association. Please let the National ESCO give us a long, their own opening remark, and they probably talk about the coming conference. So please, any of the National ESCO is given the opportunity to tell us more about what is expected in the coming national conference. Thank you.
Thank you, sir. Please, can a member of the National Expo briefly address us so that we can get to the of the day? Hello. The Pan National, the host, please, can you address us briefly?
I can see Dr. Isa. So, okay. Since the national chairman is not there, the secretary, Dr. Isa, can take it.
For meetings that are hosted by any of our specialty groups, I think what the moderator said is what we do. First of all, we get an opening remarks speech by the desk officer who tells us about their specialty group and to even advertise the group for others to join and be part of their programs, give us a brief of what they do. Then we hear the presentation. At the end of the presentation, that's when the CIPA National will come and make comments. But anyway, I still welcome us all and do hope that we'll have a very wonderful session tonight. Thank you.
Thank you, Mayoga.
Thank you, sir. Thank you very much. We stand corrected. So let me quickly introduce our speaker. He's a brilliant young man, and he goes by the name Obase Asu Benedict. He's a principal psychologist in the Federal Neuropsychiatric Hospital, Calabar. He's acquired his BSc in General and Applied Psychology, MSc in Organizational Psychology. He's an internationally certified addiction professional. He's a drug demand reduction professional. He's a member of ISOP, and he's a very intelligent psychologist. Today, we'll be talking about something that a lot of pharmacists take for granted. And I approached him and we put our heads together and came up with this topic, the psychology behind medication adherence. I believe he's going to do justice to it. And I believe that at the end of this discussion, would learn a thing or two. So, Mr. Obase, I hope you're ready for us. Can you share your slide? Mr. Obase, please say hi so we know you're around. Just say hi.
I'm trying to share my slide. Hello, can you hear me?
Yes, I can see your slide. I can see your screen.
Good evening, everybody.
Can you speak into the mic?
Hear me? Can you hear me?
Yes. Carry on. But
yes, we can.
Okay. Good evening, everybody. Welcome to.
Good evening, sir.
Welcome to this event. I want to thank you for giving me the opportunity to share the little I can with you people. Pharmacist are so hyped me. I hope I will fall her hand. Thank you. I hope you can see my slides so that we can present.
Yes, but you may need to still speak up a bit.
Okay. That's fine. Okay, I would like to start with this quote by the former US President General. He said that drugs don't work in patients. Pharmacists, you are aware of this, and it's a key thing that even our patients need to know, because without this knowledge, it becomes difficult for them to follow through with their treatment. Okay, let's look at the meaning of medication adherence. Basically, it's an agreement which has to be between the healthcare provider and the patient. They agree that, okay, you're going to take this time, this dose, this number of times, and you take it for this time. So it's an agreement reached by two people. But the bulk of keeping the agreement is to the patient, and the patient needs to understand several things. And that's the only way the patient will keep through with the medication. Of course, without that adherence, without that agreement being kept, there will be no effective treatment efficacy. As I believe most of you have experienced in your various decks or where you're working and offering service at pharmacy. Patients come back without taking medication as prescribed, and then oftentimes they come and complain of symptoms not going on, maybe other symptoms developing and all that. And oftentimes, out of shame, they might even lie to you that they took it. But when you probe, you find out they didn't take as prescribed, or they, because of one thing or the other, which we look right ahead, that could influence their not taking those medications. So there are stages in adherence. There's the initial stage, and this basically signifies the beginning when the patient takes that first dose. Because oftentimes you prescribe medications for patients, they don't buy. They just take them, oh, I'll buy later, and they will go. So taking that first dose is the initial stage. Does the patient take the first dose as prescribed? Because if the patient was supposed to start at night and then leaves till in the morning, it's not, or maybe take a different dose as regards what was prescribed. And then the next phase is the implementation stage. Here is the period between that initiation, that taking that first dose, to when the patient is supposed to end the medication. So the patient taking the dosing as prescribed, following the regimen until the last dose is taken. Then there's the discontinuation stage, which marks the end of the particular therapy, depending on the case or the ailments that is presented. So for most people then who are having chronic illnesses, they might not enter the cycle, having to come back to come and refill, and then taking as prescribed, and then following the cycle through, as against one-off treatment that one single dose to take care of the issue. And then, of course, there's the issue of persistence, which has to do with the time between the initiation stage and the discontinuation stage. So there are certain things that will happen. A patient can be non-adherent to their medication regimen if they fail to collect and take the medication on time. So a medication that maybe should have started today, and the patient decides to, okay, I've gotten the prescription, I'll buy it, and then they keep it a week, 2 weeks, it's not started as prescribed. That is if they start at all. And then that is basically what we call primary adherence. Then there's the if they follow up the regimen as whether they are taking exactly when they are supposed to take, over the period of time they are supposed to take, whether they are missing doses, whether they are cutting, okay, instead of taking maybe 10 milligrams, they decide to take 5. Okay, because they in their mind, they want to reduce whatever they think they are trying to do by doing that, or whatever. Some people, because of cost, they might do that. And then, of course, there's persistence, which has to do with the discontinuation of the treatment or continued treatment. If the patient continues to the end time, then the person is persistent. But when the person discontinues, then the opposite is the case. We have some types of non-adherence. Of course, some non-adherence is not in the hands of the patient. So there's intentional non-adherence, which includes factors such as patient not understanding how to take the medication. They didn't understand what they were expected to do. So probably out of shyness, out of fear, out of so many reasons, being overwhelmed by the diagnosis, they might not ask questions to understand what the diagnosis or what the medication, how they are supposed to take the medication. And of course, you see that oftentimes some people, because of their busy schedule, they might forget to even take, even when they've gotten it, or forget to go and get a refill. And there's intentional non-adherence where the person consciously discontinues treatment or modifies. You say, okay, if I take 10 milligrams of the drug, it makes me sleep too much. Okay, I'll take 5 milligrams. Maybe I will not sleep too much. Or because of the number of pills I have, if I reduce the dose, it will take me for a longer period of time. You know, there are so many things that can happen. This that will make the patient to have this intentional non-adherence. And of course, intentional non-adherence basically links negative perceptions about the medication. Most patients will perceive the medication as not, they are not supposed to be taking the medication, so they decide not to take it. You find that very common in mental health patients because they even go to treatment through compulsion. Their relatives who are seeing the decline got them to treatment, and they find themselves. You know, when you have a mental health challenge, as oftentimes I explain to my patients, if I wake up this morning with a fever, of course, the symptoms cause discomfort, and I feel weak, maybe have a runny nose or whatever the symptoms that might manifest. Physically, I will feel it. Or if I have a broken hand, as I wake up in the morning or even turn at night, I feel the pain. But for a mental health, for most mental health patients, you wake up, a patient with bipolar in a manic phase will wake up with so much energy, will not even sleep and will have more energy than somebody that has slept. So when you say the person is he or she is sick, like, are you okay? I'm not sick. So for with that kind of negative perception about the medication, I'm not sick. Why should I take the medication? So they end up not taking the medication. Let's look at a few reasons why there's non-adherence. One of them is fear. And fear basically.
Hello?
Hello?
Sorry to interrupt. Some people can still not see your slide. I think a lot of people can. Can you drop and share?
And reshare, okay. Okay.
Please. So just give us a minute.
Please, can they see it now?
Please, can you see the slide now?
No.
Yes, we can see cost now.
It's coming up.
I can only see your DP picture, not the slide.
No, I can see the slide clearly. Cost is showing. It has moved to misunderstanding.
That's what I can also see here.
Just put it back up and continue. I'm sure some more people will see it. Probably network.
Please, can you see it now?
We can see it. Please just go ahead. We can see cost.
Okay.
Can see.
Okay. So I started with fear as one of the reasons for non-adherence. Fear basically is about side effects. Most patients are frightened by the side effects. Probably they are taking a particular medication before, it acted in a certain way for them and they didn't like it. Or maybe they have seen that medication that is being prescribed for them acting in a friend or a relative or somebody around. So because of some of these fears, they might not want to take the medication because they don't want to have those similar side effects that they have seen manifested in other people. Another one is cost. And it's a major barrier for most people because they might come to the hospital, medications are prescribed, and they can't afford to buy the medication that's prescribed because of the high cost. Most times you find that they might not buy the complete dosage, so they end up not getting the whole. And the prescription comes with what it's supposed to do. So when somebody takes half or takes it sparingly, there's bound to be issues of treatment efficacy, issues with treatment efficacy. Then there's the issue of misunderstanding, where a patient is being prescribed drugs and they don't understand what is happening, why they have to take the medication. For most illnesses that don't manifest immediately, the symptoms are not manifesting immediately. That confusion of having to take medication for, you're not seeing what is doing or what is not doing. There's no difference between today and tomorrow. So that misunderstanding makes people not to take. And then, of course, for some people, when the side effects come, because they didn't understand them and what to do, they end up not misunderstanding what is expected of them. Most times, you find it in chronic illness. Then, of course, when a patient has to take too many medications, if you are a patient has to take too many medications and probably they have to take morning, afternoon, evening,
Go for my neck.
The fact that they have to take this many medications, they might forget and might not keep to the dosage. So this fear or this reason to help, if you give patients long-acting medications in this case, you help them in a long way. Those medications are slow release, so that even though they miss the other the orals, they can still function or have some kind of efficacy in the treatment. And then, of course, combination products are also advised in cases like this. Another reason is when there's a lack of symptoms. When somebody does not feel like, what is wrong with me? Not feeling anything. Or most times, you give a patient medication, even for malaria, the person takes, if it's for 5 days, after the first 3 days, the person is feeling a bit better. You find that most people don't take the remaining 2 days. And then it's worse in chronic illnesses, where the person is long time issue. So when, like, I have my background is in mental health. I see patients who had who came in with psychosis, of course, with other issues that resulted in the psychosis, and then you start treatment because the psychosis has resolved. Even the relative and the patient, everybody, most of the people involved, their loved ones are, it's okay. Why do you need to still take the drugs now? You're okay now, nothing. They are not seeing those visible side effects that or symptoms that they could quickly pick up. And before you know, in the long run, the psychosis might ultimately come back. And this the issue of mistrust. Of course, with oftentimes news coverage that oh, some of these medications they support with those who prescribe have a partnership with pharmaceutical companies. They are just wanting to take this up and all that. So this will also breed suspicion and it will be a motive why some people might not want to adhere to that medication. Then there's the issue of worry. Some patients worry, especially for chronic illnesses. Oh, am I going to take this thing forever? It means I'm just going to depend on this thing. Without this thing, I can't function. So it becomes a difficult thing for most people. And one way to overcome this is for communication to occur, for effective communication, which ends up giving the right message so that patients go home well informed about the medication and what the benefits and the consequences that will result if you don't take the medication. Of course, depression too can lead to people not taking adhering to the medication. Somebody who is depressed likely not take. So it's necessary that in your interface with patients, you watch out for symptoms of depression and help in maybe doing some brief intervention for those patients as regards adherence, because even the depression will need medication to resolve. And if the other underlying illnesses, everything will just get more doing up. Okay, there are some psychological explanations for medication non-adherence. The first one is social learning. There's this social learning theory where we there's the theory proposes that we learn from our environment, from the people around us, we learn from the actions of others. Just like children will copy their parents, copy their teachers, copy uncles and people in the environment. So we learn, and oftentimes we learn this medication, not adhering to our medication from the people around us. Oh, this person had this issue, took the medication, why do I have to take for 5 days? Yeah, I'm even stronger than him. I'll take for 2 days. I'll be okay. And then, of course, there's the issue of self-efficacy. Self-efficacy has to do with somebody's ability, somebody's belief in their own ability to do something. So when a patient believes that we have that confidence that we can follow through with instructions, then it helps them to also take their medication. So for those who don't believe in something, it becomes a problem. Why should I do this? So then, of course, they have the beliefs about health conditions. This can, of course, what we believe translates to our actions on a daily basis, on even smaller things that we think don't matter. So this behavior is also passed on adhering to medication. If a patient does not know what to expect and the benefits, then it becomes a problem for them. Okay, let's look at the role of the pharmacist in medication adherence. You as pharmacist, you are in a unique position. You are available even in communities where most other health professionals are not there. Pharmacists are there in local communities where you don't have most other health professionals there. They're there. So you have a unique position. You're in a unique position and you can help the patient in a long way. And it's advised that you should never assume that the patient is adherent. So each time the patient comes, assume they are not taking the medication as prescribed. And with this, if you assess, you will find out at every visit. I know the schedules oftentimes are very tight, but you could have we'll look at some key questions, prime questions to ask briefly that will help you to do this assessment very quickly at this visit. It will help in a long way. Of course, when you're giving education about adherence, it's important that you know the level of literacy of the patient sitting in front of you, so that you don't use big language. And after doing all the explanation you have done, the patient goes home not even understanding what you at the end of the day. So it's important that you know the literacy level, assess for the literacy level of the patient, so that you can now stoop to their level as you're communicating your message. And it's also, as I said earlier, when the patient believes in their own abilities to meet up with challenges and achieve their objectives. Now, if they're able to believe that, oh, this medication, if I take it, I'll be fine. It will help me to resolve whatever it is that is troubling me. It will help them in a long way. And you, through your interface with them, can help them enhance their by encouraging their past behaviors that have been positive force adherence, and then letting them know the best possible things they could do. The literature has shown that inconvenience and forgetfulness are common causes of poor adherence. So here, you can advise patients to use tools like apps, timers, the pill box. Because if a patient wakes up and has an alarm for this, we always with our phones these days. You can set alarm for the times of their medication on their phone to advise them that. And of course, I know in regards to this, I believe you know what to do as best at how you can make them to meet up with forgetfulness and the inconvenience they face, especially for patients who have very tight schedules. Okay, there's a concept in psychology we call it motivational interviewing, and it helps the patient, and it's a kind of directional relationship between the physician, the pharmacist, and in that case, and the patient. You know, motivational interview basically is like a GPS. You know, I believe almost everybody here uses Google Maps and all that. When you're using GPS and you want to move from point A to point B, most times the GPS tells you, okay, this is the best route you can follow. Oftentimes, you might decide not to follow those routes. GPS is not going to like, oh, this person, don't listen to advice. I beg. I'm leaving you. Anything you want to do, do. No. GPS will just tell you, oh, this route you're taking might cost you more time and resources. And we'll keep showing you how to follow that route still and still continue on your journey. That's the kind of relationship that motivational interviewing requires of a physician, a pharmacist in this case, such that you're supporting the patient. You're not arguing or you're trying to force the person. It's more like a collaboration. You're guiding the person towards the desired direction. And then when you collaborate with the patient, you can elicit change talk. Statement like, I can do this. I've done this kind of thing before you.
So off the water until when you finish, so that I don't waste the gas.
So you're able to set goals, helping the patient to set goals, how it could be consistent with their treatment. And of course, motivational interview expects you to show empathy to your client. You should. All of us know what empathy is. You know, sharing.
Sorry, we can barely hear. The volume is too low.
Too low. Okay, I'll try to raise my voice. Okay, so I hope I'm better now.
Yeah, it's far better.
Okay. So I was saying that empathy is key when you're interfacing with the patient. When you show empathy, it helps you to build rapport with the patient. And this will particularly be instrumental in success of the change, especially in the long term. So most times, if a patient believes they can do something, it helps them in achieving it, because that motivation will be there for them without anybody being around. They can wake up in the morning and take their morning medication, or if they have a late night medication, they take it. So when a patient has that belief in their abilities, but these things help to come out if the pharmacist asks certain questions, especially like this one. Which strategy seems like something you could try to increase? No, you're asking the patient to offer an option, because this option is coming from them on how they can do it. It now helps their ability to do it. And oftentimes, for you to get clarification and ensure that you have been able to communicate your message to the patient, it's better that you ask for feedback and clarify. And then when you're sharing your ideas, you can say, okay, this is what somebody in a similar situation is facing. Somebody that is having this kind of ailment is facing, so that the patient don't feel as if you're faulting their own behavior. And it's very key when you're assessing for non-adherence that you ask open-ended questions, not questions that will end with yes or no, or that will require patient to nod, or let the patient say something in their own words. And this will help them to verbalize whatever they are saying, so that you will now understand if they have not gotten the correct message you are trying to pass to. You get a chance to clarify. Let's look at some prime questions you could ask the patient each time they come. They bring to a prescription to you. You should ask them, what do they know what it is for? What do they even know the name of the medication? What did they tell them that this medication will do for them? Most times, because patients don't know these things, it's difficult for them to follow up with treatment, because, oh, they've given you ABC drug. You don't know what it is for. Why should you take it now when you don't know what it is for? Most times, it leads to non-adherence. And then it's key that you also ask them if they know how they are supposed to take this medication, from the dosage, the route, how they are taking, the frequency, how they will store it, how long they will take it, and everything about this. These questions help clarify, and it passes the message and helps them to go. Because if they've gotten a prescription, they don't know the dosage or the frequency or even the route or how best to store their medication. You could give them the best of medication, because how they stored it was not right. They end up not getting the efficacy from the medication. And then, of course, patients should understand what they expect from their prescriptions. What are the effects they're expecting? What do they expect to happen? So that when these things happen, they know that my medication is working. And then, of course, very key, possible side effects that could happen. Because if they don't know that, oh, this medication can cause this or that side effect, in most cases, when those side effects start coming, it's what makes them stop the medication. I've had several patients tell me to stop their medication because of the side effect. They didn't understand what was causing them, or that they could remedy the side effect and still get their medication and get the efficacy. So it's very key when they understand what to expect at the end of the day. So these questions are very key. So, and it's also important that when you've asked these questions, you should also verify to understand that they understand, get feedback, let them restate the information in their own words. And this helps the information to sink into their memory, and it will give them better understanding. And of course, when you're asking for verification, just let it don't let you should let it be as if you are not the person that is not understanding. So that if they need to blame, because these little things might make patients to not to follow through with treatment. Okay, just let me be sure that I'm understanding. Then I'm not. Maybe I didn't get you well. Is this? Did you? Do you understand that you take this medication like this, like this? So you explain to them how or whatever, so that by the time they say this in their own words, they understand it better. The likelihood for them to remember what it is when they go home, when they verbalize this information. So this is a major difference between motivational interview and normal counseling, where it's more like a lecture. The therapist or the physician just talk. But in motivational interview, you get it's an interface. It's like a two-way street, so that everybody is on the same page at the end of the day. Another key thing pharmacists need to emphasize is they need to simplify the dosing. And then, of course, this is very key, because if somebody needs to take so many medications, they might forget to take some. So, if it's possible, if it's possible for somebody to take a medication in the morning and night, you can take off the afternoon dosage, so that most time in the afternoon, most people are out at work, in school, or wherever they are, in their farms, in their business. They might likely forget that dose at home. And this results, but if you consolidate whatever effect you are trying to make them get for morning and night, so when you simplify the doses, especially for those taking multiple medications for different illnesses, I've seen patients in our practice who come in with psychosis, and they have substance use issues, and they have problems with their BP, and then they now have to take so many medications. Most are there are some that even in the whole of that mix are reactive to HIV/AIDS or hepatitis or whatever the case is. So see that at the end of the day, the medications they need to have to take are so many. So if the pharmacist could find a way to help them simplify the dosing, it will help in a long way. So it's very key that pharmacists in their practice engage patients so that they manage their illnesses better. You have a unique position in that you occupy that will help, because in most cases, even where there are no hospitals, pharmacists are there providing services, and most times you even become doctors in your environment because you need to help people. You have the knowledge already in the drug composition, so you have a unique opportunity. In every pharmacy practice, there are opportunities there for you to help patients improve their therapy outcomes. And I call on pharmacists to embrace these opportunities by always assessing for non-adherence. And of course, there are many factors that would lead to non-adherence. We've not exhausted them in this video. There are several other factors that could come in. The system would come in, because in most communities, we don't have the required facility. We need to travel far. Okay, take for example, I work in a mental health hospital in Calabar. In the whole of Cross River, this is like the only mental health facility. I have patients that travel from Oguja Northern Cross River to Calabar, which is Southern Cross River, and they spent about 30,000 naira on transport because they need to come with somebody because of their mental health state. But the medication they will need to take for the next 1 month is 6,000. But for them to come and see a doctor, be reviewed, you need 30,000 for transport. So that is the challenge. So what is stepping in for most people in that situation? The pharmacists in their localities are helping. We're able to give long-term appointments. With that now, the pharmacist is able to dispense there for them and is filling that gap. So I thank you all for this opportunity. And I hope I've made some sense. Thank you.
Thank you. Thank you so much, Mr. Obasere. This has been very enlightening. Very enlightening. Can you hear me?
I can hear you.
Okay. Please, can anyone else hear me?
Yes.
Okay. All agree with me that as the speaker was rounding up, we started seeing that we have opportunities as pharmacists to do so much more to bridge the gap between illness and wellness. Okay, so um, before we take questions, let me just quickly summarize what I learned from today's very, very interesting discussion. Unfortunately, maybe due to network from one end or the other, the slides didn't show or we couldn't hear him very well. But quickly, I just want to say he talked about how he talked about the different stages of adherence, initiation stage, implementation stage, discontinuation stage, resistance, and all that. The types of non-adherence, the unintentional and intentional non-adherence. The reasons for non-adherence are many: fear, costs, misunderstanding, lack of symptoms, lack of insight, mistrust, and I want to mention costs again, okay, because of the when he talked about depression as a cause of non-adherence, then he talked is not just for patients who are clinically depressed. Any patient who has a chronic illness is most likely going to be depressed. So it's not just for mental illness. As much as he's a psychologist and therefore works in a mental health institution, he tried to generalize everything. All the points he made are not just peculiar for mental health patients or psychiatric patients. He also talked a lot about the pharmacist role. Now, this topic is interesting because this is what we live and do as pharmacists. We do every day, but we take it for granted. We have no in-depth knowledge on how much difference we are making in the lives of our patients. And so we just that we're not doing much. We think we're doing something very simple. But I want to believe that we've learned about motivational interview, which is, I think, the new way pharmacists should engage patients. Motivational interview talks a lot about it, like a GPS. You lay everything out. It's not just you telling the patient what to do, and you don't make the patient feel like they are stupid. Sometimes you even have to take the blame. In case I did not explain it well, can you recap what I said? And I think that this is going to change a lot of things going forward. He also talked about us imbibing confidence in the patient, making the patient have confidence in themselves. When they do that, they're able to, they're able to take their drugs and adhere to medication. I think that is basically what we covered, and slides will be probably made available to everyone. So I don't know if anyone has any questions to ask or comments to make. You can do so now so that we round up. Can you hear me? Please, if you have any comments or questions, this is the time to do that. You can raise your hand or type it in the chat, then we'll address it. While we're waiting for questions of, okay, Pharmacist EE, can you unmute yourself and ask?
Okay, thank you very much. Good evening. Please go. Hello? Please, can you hear me?
Yes, I can hear you now.
Okay, so thank you so much for the presentation. I think it was very enlightening, and even though I had some issues with the audio a little bit earlier, but I think the recap by the moderators helped me to get more insight into what was being discussed. I'm actually particularly happy with the presenter being a clinical psychologist, because I think my own comment on this is just solidifying the need for a health team approach in patient management, because I believe every health professional has a role to play. I was actually very interested to hear what a psychologist wanted to say about medication adherence. And truthfully, like the moderator said earlier, I was not disappointed with the presentation. So thank you. I really appreciate today's presentation, and I look forward to a time where in the health space, we'll be able to work harmoniously and effectively as healthcare team members. So thank you, and over from me.
Thank you, sir. Thank you for your comments. I appreciate you. Somebody has said he had a few comments. Flight Lieutenant Abubakar, please go ahead. Can you unmute yourself?
Yeah, good evening. Am I audible?
Yes, you can hear you.
Okay, evening. Thank you very much, Asu Obasi, for your presentation this evening. Adherence is research is actually something that is quite, very, very important for us in clinical settings. So I really appreciate this. I just want to add a few words to the beautiful presentation you've made this evening. I think it was in 2004. I was trying to get a link to the paper to put in the comment section that the World Health Organization, published the paper adherence to long-term therapies, evidence for action. And ever since then, there's been an explosion of works and research in that area. In the paper, the policy paper, the WHO put adherence to long-term therapies at below 50%. And ever since then, estimates are usually between the region of 27 to 42%. So this actually has, a lot of importance for us in clinical practice to, take the issue of adherence, very, very seriously. And this brings to the question of how do you actually, estimate adherence? How do you get to know whether a patient is doing well adhering to a therapy? So there's a voice interference, there's a noise interference. Okay, so this actually brings, to brings out the importance on how do you get to, to know if a patient is doing well or not. Just like what the presenter have said about, not even actually getting to believe everything the patient tells you. There's like a general consensus in most of the work put out there that you don't even actually get to take the word of what the patient says. It's seen that you take it as being subjective, so you don't actually take the word, you go ahead and make your own assessments to be very objective about that. And so in that vein, most of the methods that have been put out, you have the direct method of measuring adherence, and you have the indirect method of measuring adherence. For the direct method, that will have to do with you measuring the concentration of drug from the patient fluid. But of course, that has ethical issues, attached to it. And of course, the issue of, okay, if the patient is taking 2 or 3 drugs, and for instance, interaction comes in, and it affects the concentration of one other drug, how are you sure that that is actually the best method to take? And that's where the indirect method comes in. So mostly, if you look at adherence research these days, what they do, they try to look at databases, large databases, where they use things like medication possession ratio and proportion of days covered. In that, they just try to, put in the assumption that the number of days when the drug was available, if you put it as par with the number of days in the study period, and try to put cutoff for that. But even at that, if you still look at it, it will also have some biases. And the method that is actually looked at these days as being more effective is the electronic monitoring, using electronic monitoring devices, where certain devices are incorporated into the container that stores the dosing history of the patient's prescribed medication. It's adjudged to be the best method, but it's quite limited in certain in climes like ours. So the deduction from this is that we still have to go with what the presenter have said, trying to engage more with patients, engage more, question more, look for pointers, and you can actually prioritize your patients for those on long-term care that have the propensity to default on their medicines. Then you engage them more. And for me personally, what we try to do in our facility these days is to take a leave out of the HIV program, where they have a dedicated section, the adherence counseling section. So we try to replicate that for certain long-term care diseases, then identify patients, that, could default. Then you engage them more, let them know the consequences, of defaulting. Then also try to see how to get, information from this patient and curate it, and possibly use 1 or 2 of these indirect methods, like the medication possession ratio, or the proportion of days covered, to estimate it. Once it gives you the hints, then you can now follow up, get out the patients that are, that have that vulnerability, and engage them more, and improve the outcomes of your patient. Thank you very much for the
Thank
presentation.
you so much. Thank you, sir. I'm in no doubt that pharmacists have researched the medication adherence issue. It's very, very well studied by pharmacists. Thank you so much, sir. Dr. Falan has a comment. Can you please make it brief?
Thank you so much for the. Yeah, I'm hearing you now. Are you hearing me?
Please go ahead. Go ahead.
Yeah, thank you so much. It's just a request I want to make. The flight lieutenant, at the beginning of his talk, he mentioned that there is a publication from the WHO, given that adherence in psychiatric illnesses, as well as in many other chronic conditions, is a very topical issue at the moment. I just want to request that if it is possible, we could look for and share that publication on our chat platform.
All right, I'll pass it to Dr. Abdulmumin. He's a good acquaintance. Then
Thank you.
Put it in.
Thank you, sir.
All right.
I can ask our Sudan National Chairman, Dr. Joseph Madu, is on this call. We're very happy to have you here in the call, sir. We'll call on you in a moment. I don't know if anyone else has any comments or questions to ask. In the absence of any other questions, please, Dr. Joseph, you have the floor.
All right. Good evening, everyone. Please, am I audible enough?
Yes, sir. You can hear
Okay,
you.
thank you very much, Mental Health Pharmacist of Nigeria. This is a task or your own share of the work, and you have successfully done it beautifully too. At least I can hear everyone saying that the presentation was nice. Please pardon me from my own end. I hardly heard anything. I was just hearing voice, but I wasn't really understanding. But then let me thank the presenter, who is a clinical psychologist. It's not easy to prepare for a lecture like this and to come and deliver it to us. We are very much appreciative. Thank you very much. We know that if we are to pay, especially in the current Nigeria, if we are to give honorarium, it won't even be less than something like 100,000. But I know that you have just prepared and delivered this lecture free of charge, enriching our bank of knowledge. We thank you so much. We won't blame anyone for what happened. I believe it's because of technology and network problem. Probably we shall be very happy to still have him next time to present in our association, which is CPAN. When we were drafting the constitution, we even talked about having some other persons that in the future may become members of CPAN. Of course, they will fall into affiliate members. But for now, we have not started something like that. I believe one of these days, the presenter will be one of those people we are, penciling down to be affiliate members of CPAN. That is the non-pharmacist affiliate members. It is uniform or such things are encountered worldwide. Today I heard about a HCPAN conference ongoing. Someone mentioned it on our national platform. And the person mentioned the first HCPAN stands for Healthcare, I think Healthcare Practitioners Association of Nigeria. And they mentioned that the first president is one Dr. Clive Omaseye, who is a pharmacist. And I'm aware that Dr. Clive Omaseye was made a fellow of the West African Postgraduate College of Physicians, even though she's not a physician. So we thought of things like that, that in the near future we shall have scientists and other people who contribute to clinical pharmacy and therapeutics also being part of our association. Mr. Presenter, we thank you so much. On behalf of all clinical pharmacists in Nigeria, I appreciate you and pray that the good Lord will reward you, and also pray to you that whenever we invite you next time, you will still participate, that you will still honor us to make such a presentation. Probably because of the network, as I said, I believe it affected a part of the attendance. When I came in, about 22 people, I even had to go and start broadcasting it on our several platforms. I discovered that as we are about closing, we got up to 29 persons. But this is not really the attendance in CPAN clinical meetings. Next time, we believe we shall have something higher than this. So once again, thanks to everyone. Thanks to all the participants who are here tonight to make it a reality. May God reward all of us. Thank you, Madam Moderator, for giving me the opportunity to speak. Thank you very much.
Thank you, sir. I think thank you. Can you hear me? As Super National, Dr. Madu, thank you so much for your comments, and you have noted everything you said. Please, I want to call on In the absence of any other question or comment, does anyone have any question or comment? I want to call on somebody to our chief desk officer once again to give us closing remarks before our closing prayer. Dr. Suleiman. Dr. Suleiman? Okay. Dr. Oluyinka, please, can you lead us in closing prayer? Dr. Oluyinka, can you hear me?
We can hear you loud and clear. I think her own network too. I can see that her microphone is up,
Okay.
but then she can't speak.
Okay. Let me not bother too much. Thank you everyone for coming to this meeting. Thank you. I want to especially thank our guest speaker for accepting to take on this challenge and doing a good job. I hope that if we call on you again, you'd graciously answer, and also maybe you'd share the slides so that those that were not able to hear will at least have something to take home with them. I thank every single person that joined, and may God bless you. Have a wonderful weekend and a restful night. God bless you all. Good night. Good night, everyone.
Good night. Bye-bye.
Bye.